Every few months, I see a new version of the same claim. Eat more healthy fats, and everything improves. Then another post says fat is the problem. Before we argue about olive oil or butter, what is the cleanest way to sort this?
The cleanest sort is, fat is necessary, but not interchangeable. Your body uses fatty acids for cell membranes, bile-assisted absorption of fat-soluble nutrients, energy storage, signaling molecules, and essential omega-3 and omega-6 fats it cannot make well enough. So the question is not, should humans eat fat? It is which fats, in which foods, replacing what, for whom. Mechanically, dietary fat is packaged. In the intestine, triglycerides are broken down, absorbed, rebuilt, and shipped in kilomicrons. The liver then helps redistribute fat through lipoproteins. This is why a meal can affect triglyceride traffic quickly, while repeated dietary patterns show up more slowly in LDL cholesterol, HDL, body weight, and cardiovascular risk markers.
So if someone says cut saturated fat, that sentence is incomplete? Because replacing cheese and butter with nuts and olive oil is different from replacing them with sweet cereal and white bread.
Exactly. The strongest practical pattern is not low-fat purity. It is shifting the fat profile. More unsaturated fats from foods like fish, nuts, seeds, avocado, and vegetable oils. Less saturated fat from butter, high-fat processed meats, and many desserts. A major cardiovascular advisory concluded that replacing saturated fat with polyunsaturated vegetable oils lowers LDL cholesterol and can reduce cardiovascular events, while refined carbohydrate replacement does not give the same benefit.
When viewers hear that, they may imagine olive oil working like a drug. What is a realistic expectation? A dramatic body change, a lab shift, or a risk reduction that only shows up over years?
I would frame it as a lab and risk pattern, not a magic ingredient, and there is a safety boundary. Very low-fat or highly restrictive diets can make it harder to get essential fats, calories, and fat-soluble nutrients. For most people, the target is not removing fat. It is improving the sources while keeping the whole diet adequate. Omega-3 is a good example of why we separate biomarkers from outcomes. In ischemic heart disease patients, a 2026 meta-analysis of small randomized trials found omega-3 at 1 to 4 grams per day, EPA plus DHA, lowered triglycerides by about 18 milligrams per deciliter and LDL by about 9. That is a marker improvement, especially relevant in secondary prevention, not a blanket promise that any fish oil bottle prevents events.
What about newer fats that sound engineered, like structured EPA with MCTs? If a product raises an omega-3 blood ratio, should an athlete expect better endurance or less soreness?
No automatic expectation. In a small double-blind trial of 28 healthy young men, a structured triglyceride containing EPA and DHA with MCTs raised the serum EPA to arachidonic acid ratio more than a physical mixture. But after 8 weeks, it did not outperform the comparator for leg extension repetitions or fatigue measures. Better incorporation into blood is interesting. It is not the same as a better workout. That is why I prefer food-first language. Salmon brings long-chain omega-3s plus protein. Nuts bring unsaturated fats plus fiber and minerals. Olive oil can help replace butter or creamy sauces, but it does not add fiber. The food package changes satiety, calories, micronutrients, and what you stop eating. Those surrounding details often decide whether the fat shift actually helps.
If someone has high LDL, diabetes, pregnancy, or is on medications, how should they use labels without turning this into self-treatment? Is saturated fat on the nutrition facts label enough to guide the first swap?
Labels are a good first screen. Serving size, saturated fat, trans fat if present, and the ingredient pattern. The people most likely to see meaningful benefit are those with high LDL, high triglycerides, ischemic heart disease, insulin resistance, or a diet where saturated fat is coming from replaceable foods. If someone already eats mostly minimally processed plants, fish, and unsaturated oils, the marginal gain is smaller. Inflammation claims need even more caution. Some recent studies link fat-related interventions with inflammatory markers, but the evidence is context-specific. For example, a small trial in men with obesity found exercise, and exercise plus fisetin improved markers like IL-6, TNF-alpha, fasting glucose, insulin, and HOMA-IR. That does not prove dietary fat alone is an anti-inflammatory cure.
So for capsules, the question is not just, is omega-3 good? It is dose, formulation, diagnosis, product quality, and whether the clinician is already managing lipids or blood-thinning risk.
That is the usable rule. Do not ask, is fat good or bad? Ask, what fat source is common in my diet? What is it replacing? And what marker am I trying to improve? A practical first move is replacing butter, processed meat, and high-saturated fat desserts with nuts, seeds, fish, beans cooked with vegetable oils, or olive oil-based meals. Then judge by adherence, weight trend if relevant, LDL, triglycerides, and how the whole pattern feels sustainable.